Ladies and gentlemen, welcome back to our international ground rounds, Associazione Naso, Sano. I'm very glad today one of our international panelists is Professor Hossam Elsherif. Good afternoon.
Good afternoon.
So, me and Hossam been in contact since 2015. I remember him visiting Varese while I was in there, and he attended some courses for the Milan Masterclass. He's part of the team from Egypt, and I requested him to today for having a talk regarding some complication that we might encounter during our activities, daily activities on rhinology. As many of you are aware, complications could happen. Complication could happen because of infections from infection due from other causes. So today, Hossam is going to go ahead and talk about different presentation and how to manage those complications. So be aware that this topic is going for 30-35 minutes, that we will leave the time for 10-15 minutes for question and answer. So please, for anyone interested, please type your answer and type your questions above over here. If anyone's attending from YouTube, Facebook, Twitch, please type your question and we will reply to all of them. So if you're ready, Hossam, please share your screen and let's start the journey.
Okay, thank you very much. Thank you. I'll start my presentation today about complications of sinusitis. Orbital complication of sinusitis endoscopic management. My name is Hossam Sharif. I'm from the OR department at the University from Egypt. And these are the logo of my university. And I'm proud to be a member of the Egyptian Rhinology Society and the Arab Rhinology Society. So first, we talk about some anatomical consideration. I'm sorry, where's my screen?
So we have the anatomical considerations over here.
I lost my. I'm sorry.
If you want, you can stop the sharing screen and then upload it again. Okay. No rush.
Okay.
Perfect. Great. I think that you're a little bit more advanced now.
Yes, I will go back. Okay, so we all know that the orbit is isolated from the sinus infection by the lamina peterecia and by the underlying periorbital. And we know that the periorbital will continue anteriorly. Here is the periorbital continue anteriorly, and that the orbital rim, it becomes attached to what's called the orbital septum. This is very important. The orbital septum attaches inferiorly to the tarsal plate. So the orbital septum is separating infection which occurs anterior to it in the eyelid from infection which occurs inside the orbit, and that's very important information. How can I? Okay, I will go with the arrow. And we all know that the orbital complication of sinusitis is most common. The complication of sinusitis could be orbital or intracranial, which is 15 to 20%. Orbital complication are 60 to 70%, and bony complication are 5 to 10%. In radiography, we depend on CT scan with contrast, and it's very important to do it with contrast. It is the best for orbital complications. If you suspect intracranial complication, it's better to do MRI. It's more helpful during intracranial complications. Regarding the microbiology, just a short note about the microbiology is that usually when you are dealing with complications, you are dealing with gram-positive, gram-negative, and most importantly, the anaerobes. So when you are prescribing antibiotic for complicated sinusitis, it's better to add something to cover the anaerobic infection like metronidazole. So regarding the orbital complications, the routes of spread, we have two main routes of spread, either direct spread with the organism we go through a traumatic or congenital dehiscence, or it's a retrograde thrombophlebitis. Most commonly it occurs through the ethmoidal vessels. And this is the Chandler's classification. This is a very important classification. It's from 1970, but this is the most commonly used between ENT doctors. Group 1 is preceptor cellulitis. This is anterior to the orbital septum. And then group 2 is orbital cellulitis, subperiosteal abscess, orbital abscess, cavernous sinus thrombosis. We will go through this very quickly. And this is a very important slide. I would like to all the residents to know this by heart. If you are doing a CT scan with contrast, it's very important to recognize 3 fat planes in this section. 3 fat planes. This is the periorbita, and it attaches here to the orbital septum. This is the orbital septum. So we have 3 fat planes here. First one is called the preceptor fat plane. The fat appears black. Second plane is called the post-septal fat plane, this one. And third one is called the intraconal fat plane. So whenever a resident is telling me about a complication, I ask him about the CT scan. If the infection is preceptal, then it's mild infection. The patient can be treated at home and come for follow-up in the hospital. If the infection is behind the orbital septum, like post-septum, in this fat plane or in this one, all these in the kind of complication should be hospitalized. So very important to recognize the preceptal fat plane, the post-septal, and because this will help you in the differentiating between the different stages of Chandler classification. So let's go to the first stage, preceptor cellulitis. Patient coming like this. There is no pain. The vision is okay. There is no pain. Only eyelid edema and erythema. It's not painful, but it's usually the patient will come because he sees his eye like this when he cannot open the eye actually from the edema. If you do a CT scan, then you will see that the preceptor compartment, like here, the preceptor compartment is infiltrated with infection in the preceptor compartment, but still you can detect the post-septal compartment. So the infection is limited to the anterior part of the eyelid, and this is not serious because it's not affecting the orbit actually, and it's the first stage, or what we call preceptal. So let's go to the second stage. Preceptor cellulitis, as I told you, is we need intravenous antibiotic, headbed elevation, warm compressors, and nasal decongestant, mucolytic, saline irrigation, and usually we don't do any surgical interference in this stage. Orbital cellulitis, edema and inflammation of the orbital contents without abscess formation, the eyelid edema and erythema, proptosis and chemosis, limited or no extraocular movement. And very important, if you look at the CT scan here, this is an axial CT scan, and the orbit here, you can see that the preceptal fat is infiltrated as well as the post-septal. So preceptal and post-septal, this means an orbital cellulitis. Regarding the subperiosteal abscess, here there is pus collection, and there is abscess that you can see if you are giving contrast, and this is the main advantage of the contrast, that you will see a peripheral enhancement in the abscess. Like here in this part, if it forms the ethmoid, it will push the globe forward, downward, and laterally. If it occurs from the frontal sinus, like this one, it's medial and above the orbit, it will push the orbit downward and laterally. If it's from the maxillary sinus, like this one, it will push the eye globe upward and forward. So you'll find proptosis in all cases, but the direction of proptosis differs according to the site of the abscess. You will also see chemosis and ophthalmoplegia. The complication of subperiosteal abscess, it may rupture. If it ruptures inside the globe, you will have what we call orbital abscess, or the next stage. If infection may extend intracranially and cause intracranial complication, and the risk of blindness comes from compression of the optic nerve like this. If it's posterior, like here, here's the orbital apex, here the compression can lead to blindness, or sometimes to occur by toxic neuritis. Here we have subperiosteal abscess. As you can see here, the post-septal compartment, we still have the post-septal compartment, but we have here the abscess near to the lamina brachia, and you can see here what we call obtuse angle. There is obtuse angle between the orbital wall and the abscess. And usually we can see better, sometimes we can see peripheral enhancement in this abscess. But the intraconal fat is preserved. This is the optic nerve. Intraconal fat is preserved, and it's limited to this abscess. Orbital abscess is more dangerous, but within the orbital contents, resulting from progression of the infection. It causes severe exophthalmos and chemosis, ophthalmoplegia, visual impairment, and can spontaneously drain to the eyelid, as you can see here. So in CT scan, you have this severe form of infection, which occurs inside the eye globe. There is usually severe proptosis, like here. This is the interzygomatic line, and here there is no. You can think that this is a subperiosteal abscess, but if you look at the angle between the orbital wall and the abscess, it's not obtuse. It's a sharp angle, differentiating the orbital cellulitis, the orbital abscess, from the subperiosteal abscess. The last stage is called the cavernous sinus thrombosis, and this is the most dangerous. Orbital pain, proptosis, and chemosis, and ophthalmoplegia, and symptoms in contralateral eye associated with sepsis and meningitis. It's very important to see how the cavernous sinus look in the normal MRI, normal CT scan. Here in CT scan, you can see that the contrast is filling the sinus. The cavernous is bilateral. So CT with contrast axial, and here the contrast is filling the sinus bilaterally. Here we have filling defect in the sinus. The sinus here is larger than the sinus in the right side, and this large size of the sinus with no filling can be indicative of thrombosis inside the cavernous sinus. But MRI is more helpful. If you have MRI like this one, this is a T1 weighted images of the with axial cuts, and here you can see an opacity fill the sphenoid. Here there is an opacity, there is pus inside the sphenoid, and here is, that's very important. Filling indicates that there is thrombosis, and here we have of cavernous sinus thrombosis. This is an algorithm how to treat this infection. You have to admit all cases except minor preceptal inflammation, ENT, endoscopy, and ophthalmic opinion, visual assessment every 30 minutes in first 24 hours, intravenous antibiotics, analgesics, and then you classify the patient. If they have bilateral visual and neurological signs, symptoms of cavernous sinus thrombosis, this is emergency CT, intravenous antibiotics, staph, cover, and surgical drainage. If they have visual acuity falling or gun, this is also an emergency. You have 100 minutes, sometimes it's 90 minutes to save the eye. If the visual acuity is okay, but color vision is okay, but significant proptosis, you can still have time. You do CT scan and give antibiotic, and if it doesn't improve or localize, then you go to surgical drainage. So the treatments depend mainly on the condition of the eye, the stage, and then if you, for example, if you have preceptor cellulitis, you don't have to admit. Otherwise, you admit the patient. Then you assess together with the ophthalmologist, and you start classifying the patient accordingly. Now we'll see some examples of patients. This is the first case. This is a 16 years old male. This patient is mentally retarded. He has history of left gradual proptosis for years. And suddenly, 2 days ago, he started to develop severe proptosis with lid edema and congestion. 2 days ago, severe pain following a common cold. The patient has decreased visual acuity and restricted eye movement. So this is a CT scan of the patient. Here we have this huge collection. This is a mucosal, and most probably this is an old mucosal. And the patient with common cold, they developed the infection inside the mucosal, so we start to have a second lesion. This is a second lesion. This is a subperiosteal abscess here. So we have two lesions. We have the mucosal, the original mucosal, and then we have a subperiosteal abscess. So if you look also here in this axial cut, it's more prominent. Here we have the mucosal, and here we have the subperiosteal abscess, and the subperiosteal abscess is compressing actually the optic nerve, and this may be the cause of decreased visual acuity. So during surgery, we have to drain these two lesions. The first lesion, the mucosal, and the second lesion, the subperiosteal abscess. So if we look at this video, this is the left side of the nose, and this is the middle turbinate. This is the and here first we open the mucosal. And as you can see, we have a large amount of mucopurulent discharge coming from the mucosal. We have to make marsupialization, wide opening, to avoid recollection of the mucosal. This is the nasopharynx, and this is the view inside the mucosal. Here you can see the orbit. This is compression of the orbit. The lamina pleuretia is deficient here. We have the ethmoidal vessels, anterior ethmoid, posterior ethmoid. And we have here the posterior table, frontal sinus, anterior wall, and the apex of the frontal sinus. And we have to open the second lesion. So we are doing complete FES. This is the nasopharynx, middle antrostomy, sphenoidotomy. We are completing the ethmoidectomy, and then we open the lamina pleuretia. Once we open the lamina pleuretia, we started to have this pus coming from behind the lamina pleuretia. This pus is coming from behind. If you look at the lamina pleuretia, you will see that the fluid is coming from behind on compressing the orbit. So this is the subperiosteal abscess, or the second lesion. But to ensure that this lesion is completely drained and it will not recollect again, we have to remove this part of the lamina pleuretia. The superior part is already dehiscent from the mucosal, but this part, behind this part, we have the abscess. So to remove the lamina pleuretia, we are using this J-curette to elevate the lamina pleuretia. The most important point in this situation to preserve the periorbital, because the periorbital is the barrier against spreading of infection inside the orbit. So if you are removing parts of the lamina pleuretia, take care to preserve the periorbital, because it is the barrier. Avoid the protrusion of fat in this situation. And this is the situation after completely decompressing the orbit. And this is the orbit, this is the sphenoid, skull base, and the maxillary sinus and the nasopharynx. Let's move to the second case. This is the patient. This is the patient before operation, and this is the patient after 3 days during removal of the pack. He was completely improved after draining this lesion. This is the second case. Actually, this is the 3 months old infant who came to our hospital with right, rapidly progressive proptosis, marked edema and erythema, conjunctival edema and ecchymosis with minimal response after 48 hours of antibiotics. we were thinking to what is the situation this child. We thought that CT first, and we wait for the CT. This is the CT of the child, of the infant. He doesn't have much of paranasal sinuses, the air cells, and here we have the ethmoidal bulla on the left side. Here we have the ethmoidal bulla on the right side. So here we have also ethmoidal air cells on the left side. Here the ethmoidal air cells are diseased. We have some sinusitis in the ethmoidal bulla. We thought to drain this endoscopically. So because the nose is very small, we are using ear instruments. Using ear instrument, this is a crocodile, the ear from the ear set. This is the middle turbinate, and here we have the bulla ethmoidalis. So the first step will be to opening the bulla ethmoidalis, and using the metallic suction tip from ear instrument, we are making perforation of the lamina of the ethmoidal bulla. After opening the ethmoidal bulla, we have to open also the lamina papyracea, and here after opening the lamina papyracea, removing a part of the bone, and we start compressing the orbit, and finally we have the pus coming from the orbit. This was a subperiosteal abscess. After removing part of the lamina papyracea, we could drain the abscess endoscopically through the nose, and more compression of the orbit and relieving the pressure. And finally, this will be the final situation. This is the lamina papyracea. This is the lamina papyracea after removal. This is the periorbita. We still have some pus here. This is the periorbita intact. Pus is mainly collecting between the bone, the lamina papyracea, and the periorbita. And this is the child completely normal after 1 or 2 months. So this is the third case. This is a 43-year-old female, left-sided sudden onset progressive eye edema and congestion and proptosis with decreased visual acuity and restriction of eye movement. Whenever you have decreased visual acuity, or you have subperiosteal abscess, if you have abscess in the CT, this is mandatory for intervention. If you have decreased visual acuity or decreasing visual acuity or loss of vision, these all are emergency for immediate interference of the kidney. So here in this patient, we have a very interesting observation. It was mainly from the maxillary sinus, but we have here an air-forming organism. As you can see here, the orbit is filled with gases. As you can see here, a pus and air-forming organism. As you can see here. So we started immediately. The patient went to the operation. This is the left side of the nose again. We're starting here to do medialize the middle turbinate. This is the Anselm process. Just compressing the Anselm process, we start to have a huge amount of pus. These cases are usually, the bleeding in these cases is usually severe because all tissues are inflamed. It needs more experienced surgeon. It's not suitable for a resident, for example, a new resident. You have to be a little bit experienced because you are dealing with a severe infection, and you have severe bleeding during this procedure. So after opening the maxillary sinus, we found here a fungal ball and a huge pus. The nose to find mixed pathology. We have a lot of cases with mixed pathology, fungal and bacterial at the same time. So after removal of this fungus and removal of pus, I'm starting to see the defect. From the CT scan, I know that there is a defect at the roof of maxillary sinus, through which the infection spread to the orbit. So completing the FES ethmoidectomy. and anterior smodectomy. I can go forward. Anterior and posterior smodectomy. As you can see here, the tissue is edematous. There is a lot of bleeding. Now we can see the lamina preparatio. This is the sphenoid completing the ethmoid, and now we started to compress the orbit, and suddenly we had this huge amount of pus coming from a defect in the roof of the maxillary sinus. More compression of the orbit, we started to have this huge amount of pus, pure pus coming from the orbit. This is the maxillary sinus again. This is the maxillary sinus. This is sphenoid sinus, and this is the nasopharynx. And my assistant is compressing the orbit, and here we have a defect through which we have this huge amount of pus. Again, sphenoid sinus, maxillary sinus, and we still have, with compressing the orbit, we still have amounts of pus coming, different colors, different consistencies. We have to wash the sinus because we had a large fungal ball here and severe infection. And in the orbit, we need more radical intervention. This case ended with medial medulllectomy. This is a patient before the operation, and this is a patient at the time of removal of the back, where is a very good improvement. And all these cases, the vision improved post-operatively. This is a young adult male, 24-year-old male, common or cold 10 days ago, the right-sided headache and facial pain 5 days ago, and 2 days ago, eyelid edema and proptosis, and no improvement with medical treatment. Let's look at the CT scan. Sorry, left-sided. Left side of the sinuses is completely opacified. Right side is okay. But here inside the orbit, we have something like subperiosteal abscess in the medial wall and in the floor of the orbit also, medial wall and floor. It is connected to this infection in the sinus. So let's see it's almost the same technique. This is the left side of the nose. This is the uncinate process. The uncinate is edematous and swollen, and this is the middle turbinate, uncinate process. So first is uncinectomy. When starting uncinectomy, you start to have this pus coming from the maxillary sinus. So cleaning the maxillary sinus. Then we had to resect a part of the middle turbinate because it was obstructing the view. Here we have the sphenoid sinus. And then we penetrate the lamina preparatio to drain the subperiosteal abscess. So steps is complete fist at the beginning, and then we open the lamina preparatio to drain the abscess. This is the pus coming from a subperiosteal abscess. So this is the lamina preparatio. I'm trying to decompress the orbit and remove the abscess completely. This is the periorbita. I'm trying to keep the periorbita intact all the time because it's a barrier against infection. So only the lamina preparatio. Carefully, you remove the lamina preparatio from the periorbita, and you can remove it. Continuing here on the decompression, this is the orbit after decompressing the orbit and removing of the lamina preparatio. But in this case, after decompression and removal of the lamina preparatio, we're putting our finger and trying to compress the orbit, we see that the orbit is not compressed yet. So when we started to open the periorbita, because we thought we have an abscess inside the orbit, when we open the periorbita, this is the second knife. I'm trying to make incisions in the periorbita and decompressing the compression on the orbit. Again, we started to have this pure pus coming out from the orbit. So if you feel after decompression of the orbit of the subperiosteal abscess, if you still have severe pressure inside the orbit, you may do like this. You may check if there is pus inside the orbit. because sometimes the CT is a bit old. This is a ethmoidal vessel. This is the anterior ethmoidal artery. This is the skull base, anterior ethmoidal artery. So the lamina brachia is decompressed to the skull base. This is the skull base, ethmoidal vessel, anterior ethmoidal artery, and most probably the posterior ethmoid will be like here. After completely decompressing the orbit and opening the lamina brachia, we complete the fist. This is the sphenoid sinus. This is the maxillary sinus. Maxillary sinus, sphenoid sinus, nasopharynx, and the abscess is completely decompressed. I don't want to be long, but I will continue with this case. This is a very nice child. Is 1.5 years old child who came with common colds. 1 week ago, rapidly developed eyelid edema and proptosis for 2 days ago, admitted to the hospital. He was admitted to the ophthalmology department with antibiotics, and there is no improvement. So when they consulted ENT, this was CT scan he had before. You can see here that there is a subperiosteal abscess. There is still some of the post-septal fat here and here, but there is an abscess. Because this child doesn't have IV contrast, so it's a bit difficult to see the wall of the abscess if you don't have contrast. But here for sure there is a subperiosteal abscess. Here there is a subperiosteal abscess. It's collecting in the medial wall of the orbit and also in the superior wall of the orbit. So the situation here, would you open from outside? Would you open the eyelid incision and open this child, or you go with endoscope? It depends on the if you have experienced surgeon in your team that can use the endoscope, you can go with the endoscope. If you don't, you can open from outside. It's okay, but the important thing is to open this abscess. You can go from outside, Lynch incision or eyelid incision, and you go for the medial wall of the orbit and drain the abscess, or you can do it from inside with the endoscope. We prefer to try with the endoscope. So this was the child during the operation. Also, we used ear instruments. Once there was huge bleeding in this case, and once we was inside the middle meatus, you can see here that we have necrotic tissue. Too much necrotic tissue we have to remove. I'm putting here a cotton with adrenaline to decrease the bleeding. We started to have this pus. It's coming from most probably from maxillary sinus. So I will go forward a little bit, opening the maxillary sinus. Again, we have a huge amount of pus coming from maxillary sinus, enlarging the middle meatal antrostomy. And then this is the bulla ethmoidalis. Edematous tissue, too much bleeding. The instruments are not helping you in young age, but finally we can see that this is the lamina brachia. We started to decompress the lamina brachia. This is the periorbita here, the white color. As you can see here, using the ear suction tip, I'm trying to decompress the orbit, removing a small part of the lamina brachia, a part after the other. Take your time. The most important, this is the periorbita. You have to keep it intact. As you can see here, sometimes you need 3 hands. There's one holding the suction, and one taking the endoscope, and one taking this small pieces of bone. This is the periorbita. Periorbita now it's evident, and the child improved very much after. This is the photo after 1 or 2 weeks. After 1 or 2 weeks, he became completely normal, and this is the time of his discharge from the hospital. So with this case, I will end my presentation, but I would like to invite you all to join us in the Rhino Egypt. Rhino Egypt is the biggest rhinology meeting in the Middle East. Every year we have it in the first week of March. And we have a Facebook group called Rhino Egypt URL group for all people interested in rhinology, otology, head and neck, phoniatrics, and audiology. We will be glad to if you can join us in our group. And finally, I would thank you very much. Thank you for the invitation, and I'm very happy to be with you. Now we'll see the questions.
Thank you so much, Hossam, for the presentation. We skip between the Chandler classification to assess the disease, then treatment, then surgical procedures, how to avoid stuff. So we have a complementary, a comprehensive debate on this, which is mandatory, I guess. So we have different questions around. Before going forward, please. If anyone is interested, you can subscribe to their Facebook pages and get information regarding the activities from Professor Hossam Elsherif in the future. They doing courses, congresses, and dissection courses, so please do attend them. We encourage every teaching and educational program, so it's very useful for anyone. So let's go ahead with the questions. Instead of many compliments, so we will start with the question. So Yusuf Saleh asked, please sharp demarcation bet for the preceptal, post-septal, interconal. I don't get this question. Let's go to another question. Yosef say, do you recommend middle terminator resection for cases of mucosal to improve the post-operative drainage?
Yes, in cases of frontoesmoidal mucosal, I would like to resect a part of the middle turbinate. Of course, we don't resect the whole middle turbinate, only the bulbous anterior part of the middle turbinate, because the middle turbinate is an important landmark. You will need it if you are doing revision surgery in the future, and the superior part of the middle turbinate is believed to have olfactory functions, olfactory epithelium and olfactory functions. It's very important. You cannot resect. So if you want to resect only the anterior and the inferior part of the middle turbinate, usually this part is bulbous. Sometimes with the inflammation, it's obstructing the view. So it's like trimming. It's not resection of the middle turbinate, trimming of the anterior and the inferior part of the middle turbinate, so that you can have better access and better marsupialization of the mucosal to avoid recollection.
All right. Then we have a question from Spain. Manuel is asking, are you suggesting CT scan or MRI for patients that is complaining diplopia?
For orbital complication, CT is the best. CT with contrast. If you are doing CT with contrast, this is the best for evaluation of orbital complications. When you are suspecting intracranial complications, sometimes you ask for MRI. So like cavernous sinus thrombosis, for example, you ask for MRI. So sometimes CT alone, sometimes CT complemented with MRI.
We have a question from United States, and this colleague is saying, how do you assess patients under 6 years old age if you cannot perform endoscopy in them?
Under 6 years, if you cannot do endoscopy?
I think that what
yes, if it's not available, if you don't have the scope or the facility or whatever, it's also the classic method is to open from outside, to drain the abscess from outside. So you go with incision. You may have the incision in the eyebrow, or you can have it like Lynch incision. Then you go to the bone to reach to the periorbita, and you start to separate the plane between the bone and the periorbita, and dissection here will be easy. The only problem is the anterior sigmoidal artery. But if you are a little bit inferior, you are away from the artery, you can have access to the subperiosteal abscess if it's in the medial wall. If it's in the superior wall, it's the same concept. You can open eyelid incision, go under the periorbita to drain the abscess. Then usually we put a drain at the end. We put a drain from the wound and leave it for a few days to make sure that the abscess is completely drained. This was the classic method, and it's if you don't have the facilities, the important thing is to save the eye, to decompress the orbit. So don't hesitate to do open approach if you don't have in scope. There's no problem. And this incision, eyebrow incision, is usually it's hidden and you cannot see it after a few months.
You actually replied also to another questions, by the way, because they were asking other techniques for that. Then we pass with these. Desiderius Chusi is asking, do you involve ophthalmology colleagues, and what are the key aspects, areas that you strongly have to collaborate?
Usually I involve in ophthalmology, of course, because it's mainly medical legal. You have to have ophthalmology colleague with you, and you have to assess the visual acuity. Once the patient comes to the hospital, you have to assess visual acuity, the eye movement. All these things are examined by the ophthalmology. So the ophthalmology will assess first the visual acuity, will assess the movement of the eye in different direction, the external movement, the internal movement, and will assess if it's possible to assess the fundus examination as well. And fundus examination can tell a lot of information if it's possible. So ophthalmology consultation is mandatory. It's not an option. It's mandatory. At the time of entry to the hospital, you have to consult ophthalmology. Usually we do the ophthalmology consultation every day. If you are going to give medical treatment, we consult ophthalmology every day. And after 2 days, if there is no improvement, we decide to go for surgery. During surgery, we don't need actually the ophthalmology. So the main role is in assessing the visual acuity and documenting all these things in the patient sheet, because this is a very important issue for medical legal problems. So before the patient, before the operation, you should have ophthalmology reports about the case. Don't do anything in the patient, drainage or whatever, before ophthalmology report, because it will tell, for example, the vision is hand movement, is counting fingers, whatever, and then you do another consultation after the operation and document the vision after operation before discharging the patient from the hospital. This is very important for the patient and for you to protect you during medical legal issues. But during surgery, I don't have ophthalmology colleague during surgery.
The question from Jacques from France, he's asking, do you collect a swab from the pus?
Sometimes if I have the facility, you know, and I collect. It's not mandatory, but I collect the pus sometimes. But the problem is that the patient usually, when he comes to the surgery, he had a lot of antibiotics. Before at home he had antibiotics, then in the hospital he have antibiotics. So it will not, if you do culture and sensitivity, it will not be very specific. And we know from the literature that we have all the time we have a mixed infection in these cases. So in my department we have a protocol. We give antibiotics to cover gram-positive and gram-negative and anaerobes. Myself, I will give the patient third-generation cephalosporin for the gram-negative, and sometimes metronidazole or ampicillin or amoxicillin clavulanic acid for the gram-positive, together with metronidazole for anaerobic infections. And IV antibiotics are the best in these cases. And after 48 hours, it is the time to decide if there is improvement and we'll continue on medical treatment, or we will cut medical treatment and go for the theater to do endoscopic drainage.
I think that we have the time for the last question from the Netherlands. It's in fact pretty good. It's the colleague is asking, would you perform in cases of a mycotic involvement of the preceptal space?
Mycotic, you mean fungal infection of the preceptor
Yes.
space? Yes, sure. For fungal infection, we have a lot of fungal infection in my country, and we have a lot of fungal bowl. We have a lot of allergic fungal sinusitis. We have also these days we started to have chronic fungal sinusitis. So a lot of time we are in the acute invasive, all these cases. So we have some experience in dealing with fungal infection, and all the time they are surrounding the orbit. So sometimes they are surrounding the orbit, sometimes they are surrounding the optic nerve itself. So you have to go around with the endoscope to remove mycotic infection or fungal infection from preceptal space, sometimes from around the optic nerve in the sphenoid or in this area. Especially cases of acute it's not specific about certain type of fungal, but if I have, for example, acute invasive fungal sinusitis, then I will go and remove all the infected parts, all the necrotic parts. Sometimes you have to remove the lamina fascia completely to remove the middle turbinate, inferior turbinate. Sometimes you do debridement and remove even the maxillary, the maxilla itself. Sometimes you can do some maxillectomy during this debridement. So it depends on the type of fungal infection. In fungal bowl, it's enough to open the sinus and clean it completely. In allergic fungal, the same, but in chronic invasive and acute invasive, we have more aggressive form of fungal infection. But it's common to go to the subperiosteal space during the mycotic infection.
Yeah. So we really like for your presentation. For anyone interested, there were some questions regarding pinpointing structures. So if anyone is interested, all our topics and meetings are available on our YouTube channel. You can go fast forward after the ending of this talk to participate and watch it again. Thank you so much, Hossam, for being with us. Thank you so much for being present today and participating in this. You of course be able to participate in the future for other meeting too. Thank you so much again. I would love to have as soon as possible once again to see each other. For those who's interested, we will announce the next meeting on Friday for the schedule for the next week. And a huge and a great news is coming next few weeks. Thank you so much. And I'll talk to you and see you for the next upcoming meeting. Thank you so much.
Thank you.
Goodbye,
Thank you.
Hassan.
Thank you. Bye bye. Goodbye.